الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the fourth lecture in the series titled Radiology, Diagnostic Radiology in English, referred to by the letters DRE. In this lecture, we'll handle a small subject which is concerning with the diagnosis of intracranial calcifications. This subject, as well as the following one, which is the intracranial cysts, and then the third one, which is the intraventricular tumors, will help us to understand some of the facts that has been mentioned in the previous lectures concerning some issues in the cerebrovascular stroke and also in the diagnosis of brain tumors. As you all know that calcium will appear hyperdense in the CT scan, and if you measure the attenuation value of calcium, it will read more than 100 Hounsfield unit in most of the cases. While MRI commonly show calcium as low signal in the T1 and dark signal in the T2, if this calcium is large enough to produce these changes in MR images. But there are so many exceptions for the appearances of calcium in MR imaging, including that minute calcification are seen only on CT scan but are not well delineated by MRI. As you can see in this example of a female child 2 years old having a cytomegalovirus infection, and you can see the periventricular calcification which is evident in the CT scan, and you cannot easily appreciate these calcifications either in the T1 or in the T2 weighted images. Also, you should know that some calcium will appear bright in the T1 weighted image and dark in the T2 weighted images, like this calcium in the basal ganglia, which appears bright in the T1 and dark in the T2. Then this will go into the differential diagnosis with fat, for example, and the early subacute blood, which represents the intracellular methemoglobin. And of course, for the differentiation, it's easy to have the fat suppression technique, and also you can refer to the CT images where you can easily identify the hypodensity of the fat and also the density of the blood. Then we have some physiologic intracranial calcifications that can be seen frequently and they are considered normal. Like the calcification in the choroid plexus, calcification in the pineal body, calcification in the falx and the tentorium, and calcification of the diaphragm massillae above the sella, and also the petroclinoid ligaments. Then pathological intracranial calcifications are divided into three major categories where you can easily reach the differential diagnosis of each category. The category number one is the bilateral symmetrical basal ganglia calcifications. The category number two is the periventricular calcium, and the category number three is the gyral calcifications. Then this is an example of bilateral symmetrical basal ganglia calcification where you can see calcium in the caudate nuclei and the lentiform nuclei as well. And this is periventricular calcium where you can see foci, minute foci of calcification scattered in the periventricular area. Gyral calcification will appear as in this case. You see the gyri are delineated with calcium, either unilateral or bilateral, as you can see in this condition. Then we'll start first by the basal ganglia calcification, and there is a long list of differential diagnoses here, including the idiopathic, the familial, hyperparathyroidism, hypoparathyroidism, pseudohypoparathyroidism, pseudo-hypoparathyroidism, the FAR syndrome, in cases of Parkinsonism, following radiation therapy to the brain, following encephalitis, and in cases of carbon monoxide intoxication. This is a good example of bilateral, almost symmetrical basal ganglia calcification affecting the head of the caudate nucleus, the lentiform nucleus on both sides, and also the dentate nuclei in the cerebellum. And you know the dentate nuclei belongs also to the basal ganglia. And this is another example showing extensive basal ganglia calcification affecting the dentate nuclei, the lentiform, and the caudate nuclei, with extension of calcium into the cerebral hemispheres in the frontal and in the parietal areas as well. A third example of basal ganglia calcification, and whenever you see this basal ganglia calcification, you should say that this is for differential diagnosis, including and so on, so idiopathic, familial, hypopara, hyperpara, through and so on, as you have seen in the previous list. Then we came to the second type of calcium, which is the periventricular calcification, where you can see spotty, non-symmetrical calcium in the periventricular area. And this calcium may include the congenital intracranial infection and some other conditions which can produce calcium in the periventricular area. Previously, I have referred to these types of calcification by the letters CT and CT, including the cytomegalovirus, the toxoplasma, the cysticercosis, and the tuberous sclerosis. And this is a good example of healed cysticercosis. We'll discuss this in the lecture of intracranial infection and inflammation, where you can see here multiple periventricular calcifications scattered in both cerebral hemispheres. Then the congenital intracranial calcifications, congenital intracranial infection may present by intracranial periventricular calcification, and you all know that these group of infections include what's known as the torch group, which indicates toxoplasma, rubella, cytomegalovirus, and the herpes simplex type 2. In these intracranial congenital infections, you can see periventricular foci of calcium scattered non-symmetrical all through the periventricular area. Then if you see a calcium like this, and this is periventricular, intimately related to the ventricular wall, then you may think of cytomegalovirus infection. Some said that whenever you see periventricular calcium and you want to differentiate between cytomegalovirus and the toxoplasma, you may look to the distribution of calcium. If the calcium is intimately related to the ventricular wall, then you may suspect the cytomegalovirus infection. But if the calcium is a little bit away from the ventricle, concentrated in the basal ganglia, then you may think of toxoplasma. But this is, as you all know, not a rule, and many of the overlapping pictures can be seen. Then we came to the tuberous sclerosis, which is one of the diseases produce periventricular calcium. It's not in the group of torch, but is one added to this group. Then the tuberous sclerosis is a neuroectodermal disorder, and this is the incidence 1 every 150 150 as you can see, this is the incidence, and this disease is diagnosed by the well-known clinical triad, which includes adenoma sebaceum and the seizures and the mental retardation. By adenoma sebaceum, we mean that there are multiple cutaneous tumors located in the skin, and they also occur all over the body, everywhere, like in the retina and in the kidney and the many organs. And this adenoma represents one of some of the tumors of this tuberous sclerosis, which are mainly formed of normal tissue in abnormal location, so they are known as hamartomas, as you can see. Then hamartomas can occur in the lung, in the brain, in the kidney, in the skin, in the heart, and other organs. And these hamartomas are, as you all know, composed of normal cells, but they are present in abnormal location or in abnormal distribution. The calcium will occur in the lesions by the increase in the age of the patient. That's to say, in newborn and infants, you may see periventricular tubers which are not yet calcifying. Then after that, and by the age of 20 years, 100% of the nodules will be calcifying. But progressive calcification of the nodules will increase with the increase in the age. Then the hamartomas will include a very well-known category in the kidney and the liver, which is the angiomyolipoma, and cortical and subependymal tumors of the brain. Most of the tumors may occur in the wall of the ventricle, but some of the tumors may occur in the brain parenchyma subcortical or cortical. And subependymal giant cell astrocytoma we mentioned now, rhabdomyomas of the heart, and lymphangioliomyomatosis of the lung, and we will also give you an idea about this. And look at this patient with multiple periventricular foci of calcium scattered intimately related to the ventricular wall. And this represents the hamartomas or the tubers of the tuberous sclerosis. Calcification will progress with age, as I have said. And in this patient, this particular tumor, as we have mentioned in the lecture of brain tumors, one of the low-grade gliomas or astrocytomas is the subependymal giant cell astrocytoma in patients with tuberous sclerosis. And in this case, you can see a soft tissue mass located in the frontal horn of the right lateral ventricle. The mass contains calcium. In a patient with tuberous sclerosis, then the diagnosis is subependymal giant cell astrocytoma. And you remember that I have mentioned that you can see calcium in the CT, but it's difficult to appreciate in the MR images. In this young patient, we can see multiple tubers which are not yet calcifying. And in the MRI, you can see also the tubers in the wall of the ventricle. They are somewhat bright in the T1 and low signal in the T2 weighted images. And this is an example of a large subependymal giant cell astrocytoma present in a patient with tuberous sclerosis. And you can see the calcified tubers in the wall of the ventricle, and you can see the tumor which is commonly located in the frontal horn of the lateral ventricle, and this tumor may contain calcium, and it should show homogeneous contrast enhancement in most of the cases. This is considered a very rare tumor, is particularly seen in patients with tuberous sclerosis, and they have a particular location and a particular imaging findings. This is MRI of a patient with tuberous sclerosis showing multiple tubers in the wall of the ventricles, and in the contrast enhanced MR T1 weighted image, you can see enhancement of the tubers as well as enhancement of the subependymal giant cell astrocytoma in the frontal horn of the left lateral ventricle. And this is one of the common manifestations of tuberous sclerosis in the chest, where you can see multiple very small cystic changes in the lung, which are almost similar to the changes of lymphangioliomyomatosis in the lung. And these cystic changes are seen in patients with tuberous sclerosis. Some of these cysts may rupture, produce pneumothorax, and sometimes the chylothorax also or chylous effusion may be seen because of the lymphatic component of this particular disease. In many cases, you can see pulmonary changes as well as angiomyolipomas in the liver and the kidneys, particularly the kidney. As you can see in this good example of tuberous sclerosis, here is subependymal calcium, typical of tuberous sclerosis, and the chest shows multiple small cystic air-containing lesions throughout both lung fields. Also, you can look at the kidney where there are bilateral large angiomyolipomas, fat-containing lesions involving the renal parenchyma on both sides. Uh, Then we came to the viral pattern of calcification, which is seen in Sturge-Weber syndrome. And the Sturge-Weber syndrome is also one of the neurocutaneous diseases, and clinically, it may present, usually commonly present by seizures, sometimes by hemiplegia, mental deterioration, glaucoma, and the facial port wine stain may be also seen on in the patients. Then the CT scan will show some gyral calcifications, when this calcification may be unilateral or bilateral, commonly affecting the temporooccipital area, but may extend into the parietal and also in the frontal area. And bilateral lesions are seen in 20% of the cases. The common location is the parieto-occipital more than frontal. Gyral calcification is usually seen after the age of 2 years. And you should know that one of the manifestations of this disease is hemiatrophy of the affected cerebral hemisphere and enlargement of the choroid plexus ipsilateral to the lesion. And you can see a case of Sturge-Weber with cortical calcification, atrophic changes of the calcified area, and hypertrophy of the choroid plexus, which is ipsilateral to the site of the lesion. And this is also a case of Sturge-Weber syndrome by CT and by MRI. And the CT shows the classic chiral calcification in the occipital area. The MRI will show enhancement corresponding to this vascular abnormality and the enlargement of the choroid plexus, which may show homogeneous contrast enhancement, as you can see. And this is also a case of Sturge-Weber showing by CT cortical gyral calcifications. On the MRI T1 post contrast, you can see a relative loss of volume of this part of the brain, enhancement along the surface of the brain, and hypertrophy or enlargement of the choroid plexus. Then there are a long list of non-diagnostic calcium in the brain. And by non-diagnostic calcium, I mean that whenever you see this calcium, you cannot reach the differential diagnosis unless you have a supportive clinical or other imaging finding. And these non-diagnostic calcium may include vascular calcifications as seen in arteriovenous malformation, aneurysms, and the hemangioma or cavernoma in the brain, and also in arteriosclerotic changes. Metabolic intracranial calcifications may be seen as in cases of carbon monoxide poisoning, folic acid deficiency, hypervitaminosis D, homocystinuria, lead poisoning, and Wilson disease. And inflammatory etiology of calcium may be seen in healed brain abscesses, fungal cerebritis, parasitic disease, cysticercosis, hydatid TB, and toxoplasma. Also, some neoplastic, some tumors can show calcium, like commonly the meningioma. Sometimes some types of gliomas, like the oligodendroglioma, deposits, neurofibromatosis, lymphoma, and leukemia after treatment, and in cases of dermoid cyst. Also, traumatic lesions like the hematoma and the scarring or the needle tracks may show some calcium. And this is just an example until we can manage this infection in the lecture of intracranial inflammation and infection. And this is a good example for intracranial active tuberculosis, showing the typical buttonhole enhancement and surrounded by evident perifocal brain edema. And this is calcium, which is seen in an oligodendroglioma, a tumor which is located in the posterior hyparietal area of the left cerebral hemisphere, showing matrix calcification. And this is a case of subfrontal meningioma, and the meningioma shows some calcium inside, and after contrast enhancement, there is homogeneous post-contrast enhancement. Dermoid cyst is one of the lesions that contain calcium, besides the fat content, as well as other soft tissue structures, as you can see here. Then in arteriovenous malformation, you can see linear pattern of calcification, as you can see in this case. And whenever you inject the patient with contrast, then you can see serpiginous enhancement, which is classic of an arteriovenous malformation, which will be mentioned in full details in the lecture of intracranial vascular lesions. And I thank you very much.